I got my DLO, that is Diploma in Laryngology from Royal College of Surgeons of England. Then I got my FRCS from Edinburgh. Later I got FRCS from England and FRCS from Glasgow. I worked in Edinburgh Royal Infirmary and shifted to Ireland actually. I was in Ireland for 3.5 years and ultimately came back home long ago. By this time I also went to Saudi Arabia as a consultant, worked for 1 year actually, and then came back again. So basically, this is the thing. But I've been here for a long time. I worked in Saudi Arabia only for 1 year. Incidence of thyroid cancer has been drastically increased over 30 years. If we study America, England, other countries, Japan, Korea, like Korea, 15-fold increase of thyroid cancer. In USA, actually, if you compare from 1975 to 2019, so it was about 4.9 per 1 lakh, which has been raised to 14.3 per 1 lakh in 2019. So how much it is increased? Even in female patient, is more increased. It's coming from about 6 to 24. So that means 4 times increase in female patient. In Bangladesh, it's not out of that. In Bangladesh, we are getting lots of thyroid patient in Bangladesh, and I am coming from Bogra, the northern region of Bangladesh, where the iodine deficiency or endemic area of thyroid swelling. And from that, actually, recently, I had one study. It was published in 2019 in Open Access Journal in USA. And I showed there that out of 3 patients of thyroidectomy, what I did operation after getting biopsy, out of 3, 2 is coming as a benign and 1 is coming as a cancer. That means in that study, about 32.8% cancer in the thyroidectomy patient. So imagine how much it is increasing. Even in Dhaka, a recent study I did, one of my Bangladesh Journal of Otolaryngology published this year, I showed 200 patients of thyroid patient coming from all over Bangladesh, and it also showed out of 3, 2 is benign, 1 is cancer. So we can imagine now how much cancer is increased nowadays. And you ask this question, why the reason of this increasing, right? This question is why this increase? Really interesting question, because why it is increased? One thing is, there is some answer for that question. One is, well, we have nowadays most diagnostic facilities is lift up. That means we have more diagnostic facilities, and that means reason that early diagnosis, sometimes undiagnosed case can be diagnosed early. Patients are very conscious nowadays. If the patient has got some lump in there, oh, I have some lump, I have to come to doctor. So they are more conscious. So we are identifying more and more patients. This may be the reason. Also, environmental pollution, we're exposing the ionizing radiation. Iodine deficiency, not only the cause of thyroid cancer like follicular carcinoma, but there is some area like your China and Japan, there's some area where there is increased intake of iodine because of they take fish, actually, seafood like seafish, more iodine is there. So that can causes BRAF positive thyroid cancer, papillary thyroid cancer. So iodine is also important factor. Apart from that, ionizing radiation, the patient may have exposure of radiation before. Patient has some environmental carcinogens unidentified, like your benzene, like your formaldehyde, some other asbestos. Also, this is not that much proof, but still, all these factors, food habit, obesity, all may contribute of increasing thyroid cancer. Nowadays, out of about 2.1% of the thyroid cancer is, if you compare the whole body cancer, thyroid cancer is 2.1%. If you compare the head and neck cancer, about 10 to 12% is thyroid cancer out of head and neck cancer. Any patient, if the patient comes with a lump in the neck, which moves on degradation, that means a thyroid swelling, we understand. Now, we have some basic investigation. With this investigation, we can identify, yes, this can be a case of cancer. What are those? First thing is we do simple TSH test, thyroid stimulating hormone. TSH level, if it is is normal or a bit high, it indicates patient have hypothyroid. So there is least chance of cancer. Sorry, there is a more chance of cancer if the patient has got TSH level is high or normal level. But one thing is important: if the TSH level is very low, it indicates toxic. That toxic cases, the chance of cancer is least or very, very minimum chance. So TSH level can give some idea, number one. Number two, investigation is we do ultrasonogram of the thyroid gland and neck. So, and that is one of the important tests for assessing the thyroid swelling, either it is benign or malignant. Now, ultrasonogram give lots of information about the structure, like suppose the size of the nodule is important, either a nodule is how much centimeter, because this is a marker we divide this low risk group, high risk group. Number two, number of nodule. If the patient has got single nodule, the more chance of cancer than the multiple nodule. Patient with multiple nodule, 1 to 2% or 3% chance of cancer, but single nodule, chance may be high, up to 25% sometimes. It depends on. Next is solid or cystic nodule. Ultrasound gives solid or cystic. Solid, more chance of cancer. Cystic, least chance, about 1/4 chance less in cystic swelling. So ultrasound give that idea. Number four, ultrasound give suspicious of cancer. There is some parameters of ultrasonography, like the patient that might have some irregular nodule, number one. Number two, hypoechogenicity of the nodule. Number three, microcalcification of the nodule. Number four, there may be more tall cell than the less tall, wider cell. Other things is if the presence of lymph node. If the patient has ultrasound shows, oh, there are multiple lymph nodes with this nodule, more chance of cancer. So ultrasonography gives lots of information regarding either the patient may be benign or malignant tumor. Number three test is a very, very gold standard test is fine needle aspiration cytology or FNAC. This FNAC will take some sample from the nodule, and we do under microscope, we examine under microscope cytological examination and see if the patient has a cancer. Now, FNAC can give clear idea about papillary carcinoma, about anaplastic carcinoma, about medullary carcinoma, about lymphoma. But it has got drawback, it cannot differentiate follicular carcinoma from follicular adenoma. That is a drawback, but still, it identifies about 80% or 70-80% cases of cancer with FNAC. These are the basic three diagnostic tools for diagnostic cancer. But if we suspect medullary carcinoma, we can do thyroid calcitron. If we suspect extensive tumor arising here and there or metastasis to other, then you can go get a CT scan, or you can get a CT chest or PET scan. But these are the three basic investigations for diagnostic thyroid nodule cancer. As you know, for diagnostic of cancer, actually, our gold standard is your fine needle aspiration cytology. So, what happened here? FNAC has got some limitation. Like in my case, in my study, as I said, 2 studies I did. So, FNAC shows out of 4, 3 benign, 1 cancer. But after histopathology, after getting the biopsy, it shows 3 out of 3, 2 benign and 1 cancer. So there is lots of false negative results in FNAC. There are some drawback of FNAC. What are those? Like limitation of FNAC? Like it depends on adequate sampling. Sometimes the patient may have inadequate sample. Experience of the cytologist is also important. That who is taking their sample, their experiences. It also highlights the report. Number 2. Number 3, there may be sometimes your mixed pathology, like patient have cancer associated with thyroiditis, patient have cancer associated with multiple nodule, patient have combined papillary and follicular lesion. So there are lots of limitation of the FNAC and have give lots of false information. Suppose FNAC shows this is a cancer, and we did total thyroidectomy operation. After histopathology come out benign. oh my God, what I did? Patient lost his thyroid, and even putting the lots of complication. So these are the drawback. Now to overcome this situation, now the MALDI, that means matrix assisted laser disruption imaging or MSI is available nowadays. Although it is not available in Bangladesh, but still it is available in all the Western countries other, and that is the things that they can study the molecular level of the tissue. That means sampling is, if something is coming up, and they study on that sample, on the cytological sample, to see that what is going on inside regarding the molecular biology, pattern of the cells, protein genomes, protein signature, so that with this, not only that, also they can see the biomarker of the tumor. So this can give a clear idea that this behavior is the cancer behavior and this is a benign behavior. So they can differentiate benign from malignant. And now the days are coming when we'll be much more reliable on this multi-technical, multi-imaging rather than FNS, because FNS has lots of drawback, multi will not. So multi will give more sensitive, more specific than the FNS. Actually, CCND1 splice variants is a novel diagnostic and predictive biomarker for thyroid cancer. It is already lots of studies going on, like recent study of 286 thyroid tumors. One study I have seen that they showed there is actually there are CCND1 B actually, which is a wild nature, that there is overexpression of the CCND1 B on messenger RNA, and this is very much close to the linked with the papillary thyroid carcinoma, and CCND1B expression not present in other cancer. So this can differentiate that this is papillary carcinoma, not this. And even the overexpression of CCND1B can give an aggressive nature of the papillary carcinoma thyroid when we cannot treat with a logical way. So this can give an idea of the predictive value as well of the papillary thyroid carcinoma. That's why this is also important. The studies going on and lots of studies going on about the CCND1 slice. For the general public, I am saying in a very simple way that how do we manage, because patients expect more from us. Now it depends on in what stage the patient has come to us. So we usually, as you know, the most of the thyroid cancer is papillary carcinoma. In my study, I showed about 92% papillary carcinoma. So that means mostly papillary carcinoma. Hardly we get follicular carcinoma, anaplastic, medullary carcinoma, hardly 5%, 3% like that. So we are dealing with the differentiated thyroid carcinoma, papillary and follicular. Now this cancer we divide into two groups. One is low risk group, another high risk group for the treatment purpose. What is low risk group? That means when the patient has come to us with ultrasound shows about up to 4 centimeter nodule, the single nodule on one side, 4 centimeter. There is no up to 4. It may be 1, maybe 2, maybe 3, but up to 4, not more than 4. And there is no lymph node metastasis, clinically as well as biochemically, or no lymph node metastasis, no distant metastasis. Patient is a female patient. The age is around 45 and below. So this we categorize in the low risk group. Now, if this person has come to us with a differentiated thyroid cancer, like papillary carcinoma, we go for only this side. That means hemithyroidectomy or lobectomy. We excise the thyroid lobe one side with isthmus, but we will not disturb the other lobe, so that we can have other lobe intact. So this patient ultimately after operation, getting a biopsy, what it says. Biopsy, yes, it is papillary carcinoma confined to that lobe, no extracapsular invasion, no other structure invasion. So we'll only give post-operative thyroxine supplement at a level of 1.5 or 1 level, but no need of radioiodine ablation. So this is low risk group. Now, in the low risk group, we plan for hemithyroidectomy, but the biopsy report came up extracapsular invasion. Then we'll go for, the question is, we'll go for the completion thyroid or other, then radiation ablation. Now talk about high risk group. Who are the high risk group? If the patient has got more than 4 centimeter nodule, patient has got lymphatic metastasis in the neck, patient have got tracheal invasion, all these, or even distance. So this group we go for total thyroidectomy operation. We remove the both lobes with preservation of the recurrent laryngeal nerve and parathyroid, and we excise the lymph node chain, central compartment, as well as level 2 to 3, 4, 5B. All this lymph node will excise. After that, we'll go for radioiodine ablation. That is very important. And we will keep the TSS level with supplement about 0.1 or below level. This is a strategy. And we will follow up the patient regularly with TSS and TG level, thyroid globulin level, because there's a marker. If the thyroid globulin level will keep on high, either is level high or not. Eventually, we'll follow up the patient. If the TG level is high, then it can give recurrence, although less. Then we go for a PET scan, all these to see that, and give for another radioiodine ablation. So this is this group of patient. Now, what about the medullary carcinoma? Medullary carcinoma, usually we go for total thyroidectomy with neck dissection. What about anaplastic carcinoma? Anaplastic carcinoma, we is inoperable mostly. We go from tracheostomy, pallidary treatment. Sometimes we go for total thyroidectomy, but patient usually prognosis is very bad. Within 6 months, patient will die. So this is the logical approach of thyroid cancer management. If the patient has got papillary carcinoma thyroid, oh my God, jump up, chop the head. That means total thyroidectomy. Even the tumor size is very small. Why we did that? Because we thought, oh my God, papillary carcinoma has got multifocal. That means it's a multifocal. There may be some other reason, but on that ground. But it is proved that nowadays, with American guidelines and other British guidelines, that even the multifocal, there is chance of recurrence is very less or minimum. So now the strategy has been changed from total thyroidectomy to localized to hemithyroidectomy. As I said, that's how we categorize the patient, that who are going to do hemithyroid, who are going to do total thyroid. Initially, all thyroid cancer patients, papillary carcinoma, follicular carcinoma, chop the head, that means total thyroidectomy. But now, no. Differentiated thyroid carcinoma, low risk group, tumor size small, we will not go for total thyroidectomy. We will go for hemithyroidectomy. And no need of radioiodine ablation on this group. Only thyroxine supplement to keep TSS level about 1 or 1.5. So that strategy has been changed drastically nowadays, and we are following this rule of American Thyroid Association guideline. As you know, differentiated thyroid carcinoma with the papillary follicular carcinoma, they are very much dependent on iodine. So we can ablate the tissue with radioiodine ablation. But there are some thyroid cancer differentiated which sometimes is refractory to iodine therapy. That means even giving iodine therapy, they behave aggressively. Oh no, I am not taking iodine. I am rigid. So this group of patients of refractory differentiated thyroid carcinoma. And what about the other cancer? Anaplastic carcinoma, medullary carcinoma, they are not sensitive to radioiodine therapy. So what to do? They have to sometimes chop the head, but high recurrence, distal metastasis, all this. So on the basis of that, the research is going on molecular level, and then we are now implementing the new technology is your. What you have said that the new drug actually pembrolizumab is a drug, actually is a anti-PD-1 monoclonal antibody, and that is a tremendous study is going on pembrolizumab. Why? Because of effective treatment of these cases. That means refractory cases of papillary carcinoma thyroid, metastatic carcinoma, medullary carcinoma thyroid with metastasis, recurrent medullary carcinoma, anaplastic carcinoma, and they have showed that, my God, because this cancer has got very least prognosis, but nowadays with the help of this drug, the prognosis is fantastic, and with the survival benefit is high. So nowadays there is a hope of this drug, this pembrolizumab, as an effective treatment of this group of cancer, like this anaplastic carcinoma, medullary carcinoma, metastatic medullary carcinoma, recurrent cancer, and also refractory papillary carcinoma of thyroid gland as effective treatment nowadays, apart from this other. So this is a fantastic development in thyroid cancer management. Is your pembrolizumab. Because Now the question of molecular therapy is coming up, because as you know, we are helpless to other group of cancer, like as I said, the anaplastic carcinoma, medullary carcinoma, thyroid, and also refractory papillary carcinoma. We don't have any hope actually. But as we are going to study on molecular level, the genetic studies are going on. So with the molecular technology, we can study the molecular behavior of the tumor. We can see the protein genome, protein signature. We can see the target molecules as well as the target particles. So all these molecular markers we are evaluating. So with the help of these molecular markers, we are also evaluating the lots of drugs, as you know, the pembrolizumab and other drugs. So this is now lots of studies going on for this drug, and it's very much effective for this treatment. So this is a new landscape actually. Thyroid cancer management is really the molecular landscape. As a molecular study were going on, genome change has been going on. Every time is changing. So we can stop that one by giving the molecular therapy or immunotherapy. Now, how it helps actually? This molecular genome or molecular therapy helps to improve the immunity. So our target is to improve the immunity. This is one type of immunotherapy, so that we can increase the number of CD4, CD20, all the other cells. That means that we can natural killer cells, NK cells, we can memory cells, so that we can increase the B lymphocytes and other lymphocytes, so that can destroy, that can block the tumor, that can regress the tumor. So this is a new landscape actually for the treatment of the thyroid cancer. So eventually, in some days coming up, that even the roll-up surgery is going down, and this new era of treatment is coming up. So this is a new hope for us, where we are really seeing, patients dying. But now the days are coming, no, patients not dying. We have this landscape. Actually, for the new generation, I was planning to be a general surgeon. In old days, I graduated in 1987, and after internship, I was very much depressed, because what to do? I wrote a surgical book on those days, and it was very popular, all about Bangladesh. They usually read my book. So I was planning to be a general surgeon, but what to do actually? Which subject I will be specialized? So one of my roommate just was there. He was doing ophthalmology. So I went to him, and he said, "Dr. Matin, the day will come up when the scope of general surgery will going down and down, but the ENT and other subspecialty will come up. So please read ENT." Alhamdulillah, I read ENT, and I am not repentant of my subject. ENT is a fantastic subject. Why? Because it has got multiple disciplinary approach. It has got medicine. It has got surgery. We have lots of patients in the outpatient clinic like medicine. Also, we have lots of surgery like ear, nose, and throat. We have head and neck. We have reconstructive surgery. We have maxillofacial surgery. That means it's an expanding subject. So this is a fantastic subject. If any new doctor is coming up in this field, I must appreciate that this is one of the best field in medical science, because this is lots of subspecialty is coming up, but it is expanding. We have ear, nose, throat. We have head and neck. We have reconstructive surgery. So you have to, if you want to build up your career, I am promising you, I am giving assurance that you will not be repented for that. And how to do that? Well, as you know, there is lots of scope in Bangladesh, in India, Pakistan, in UAE, in England. If you want to do your career in your local, like MS, because I am also an example of MS, DLO. I'm making question of DLO, MS as well in Bangladesh, in university. So you can, lots of fields there, MS, DLO, MRCS in otolaryngology. Eventually, then you have FRCS in otolaryngology. So this is a fantastic subject. You can do training locally. You can just have lots of session training experience you can get from anywhere in the globe. So I must appreciate that we have lots of things like otology. You can then, after getting your ENT, you can have some subspecialty in any other particular subject, like your nose, like your otology, like your head and neck. So there are lots of things to work, and we have lots of patients coming up. Lots of. In my experience in Bangladesh, most of the ENT doctor, those who are even newly graduated and newly trained, they are doing very good. Actually, this is because we didn't know it even. With this corona situation or pandemic, now we invented this technology. Even nowadays in Bangladesh, we made a online academy of otolaryngology, and every fortnightly we are discussing one case, like a case of sinus cancer, like a thyroid swelling, like a case of parotid, and one just simulating. I mean, the recording the video of the how you take the examination. Then we are the examiner posting the examining and giving the answer. So this is a very good technology nowadays. The viewer is also increasing. Even I am giving lectures in my lecture gallery with this webinar as well, and we have a session of webinar as well. So this technology will come even when your corona will finish up. I don't know when we'll finish up with the corona, but still there is a good technology we learned actually that yes, we can also continue our education through this digital learning program, through webinar. We can attend anywhere in the globe with this session. We can also view the video, the operative video, but other interaction we can watch, we can join as well in the webinar. So this is a very good technology. It's a very good media of learning as well with digital learning. So eventually it will succeed.